So we're going to continue on with our focus on pain, and I'd like to introduce and invite Dr. Smith. Dr. Grant Smith is a clinical associate professor of primary care and population health at Stanford University and the medical director of the Stanford Palliative Community Partnership Team. He provides both inpatient and outpatient palliative care services through Stanford Medicine, and his talk today will focus on using medications as one of the ways in which we can manage pain in both acute and chronic settings. So thank you, Dr. Smith, for joining us today.
Good morning, everyone, and thank you so much for having us. I'm really excited to talk today about pain medications. To give a little bit of a roadmap of what we'll be talking about, I'm going to start with a framework that I use to just think about all the different pain medications we have and how to start utilizing them. We'll review some of the common pain medications you may have used over the counter at home, some medications you may have been prescribed. We'll talk briefly about how they work, some of the side effects or precautions to look out for. And then for some of the medications, I'm going to provide some pro tips for how to sort of optimally use those medications safely. And then I'll have a little bit of conversation about mucositis and topicals. So let's start with the framework for pain management. And I often think about this pyramid image. And in the pyramid, I think about the base of the pyramid as being our safest and still effective medications. And as we go up that pyramid, there can be some increasing risks of side effects or adverse effects. But one thing to note is that that doesn't mean that the risk-benefit ratio doesn't go up as you go up the pyramid. So sometimes we need strong medications that may have side effects to benefit our quality of life. So it's definitely okay to use these medications when they're needed. We just think about this whole pain management plan together, and this is a framework I try to keep in mind. Like Jake and Amy were saying, we try to think about, well, what's the etiology of this pain and what's happening in the body? So overlaid on this pyramid, I'm often thinking about, well, what's causing the pain and what do these medications target? So medications like acetaminophen or Tylenol can target that nociceptive pain that Amy was talking about and also may help with some inflammatory components of pain. Our non-steroidal anti-inflammatory drugs, or commonly known as NSAIDs, and steroids are potent anti-inflammatories, so they really help with inflammatory pain. Next on the pyramid, we have a whole host of medications that help with that neuropathic pain. We'll talk more about what that is in these medicines, but that includes things like gabapentin or Neurontin, pregabalin, also called Lyrica, duloxetine, also called Cymbalta, and venlafaxine, also called Effexor. And then the top of our pyramid are the medications in the class of opioids. We'll talk quite a bit more about those medications. They can help with nociceptive pain and neuropathic pain. Again, these are fine tools to use when we need them, even though they're at the top of the pyramid. So let's start with acetaminophen. You may know this as Tylenol, or some people know this as paracetamol. How does Tylenol work? Well, we actually don't fully know, even though it's a common over-the-counter medication, but we don't know the full mechanisms. We do think that it works somewhere in the central nervous system, meaning in the brain and spinal cord. We think it may interact with the serotonin system or something called the endocannabinoid system. Yes, that's related to cannabis products, but it's really not entirely understood. One of the common issues that I'm often talking to people about is the safe dosing for Tylenol. And their safest recommendations for people who have no liver issues, and we think about the liver with Tylenol because it's processed in the liver. So if your liver is healthy and normal, we often think of a safe dose as being somewhere around 3,000 milligrams in a 24-hour period. So often people might be taking 1,000 milligrams 3 times a day. 1,000 milligrams of Tylenol is 2 extra strength Tylenol. If people have liver injury or liver disease, we reduce that total daily dose to 2,000 milligrams or 2 grams a day. And you might take something like 1 extra strength Tylenol or 500 milligrams 4 times throughout the day. You really should probably avoid Tylenol if something is actively going on in your liver. So if the liver has active inflammation, and you definitely don't want to take Tylenol while also drinking alcohol. Now, a common conversation I have in my clinic is people say, look, doc, I've taken Tylenol. It does not take away all my pain. So I don't want to take it anymore. And I totally get that perspective. I also just go back to my pyramid and I think, well, gosh, if there's some component of your pain that could be treated by the Tylenol, it's one of our safest medicines we have. Why don't we use that to at least cut the pain down maybe 5%, 10%? And of course, we'll go on to use maybe stronger and other medications to still treat the pain. Let's move on to talk about those non-steroidal anti-inflammatory drugs, or NSAIDs. There are a whole lot of NSAIDs out there: ibuprofen, naproxen, aspirin, celecoxib, meloxicam, diclofenac, ketorolac. A lot of them are out there. How do NSAIDs work? Remember that image that Amy and Jake showed that had all those abbreviations of things like prostaglandins and all these other sort of substances in the tissues? Well, this helps to reduce some of those substances in our body that cause pain. And in particular, these enzymes called the COX-1 and COX-2 inhibitors. It inhibits those enzymes. And it also reduces prostaglandins, which are very pro-inflammatory in the body. So think of your NSAIDs as an anti-inflammatory medicine. NSAIDs can be very effective, and they come with quite a few potential side effects. So one, it can be some stomach issues. Those COX enzymes, when they're inhibited, can reduce the protective lining in our stomach, and so there's a risk of stomach ulcers. Fortunately, we can reduce the risk when those medicines are taken with a meal, with food, to help kind of line your stomach with the food. Or some people will take NSAIDs if they need it on a regular basis with an acid reducer, something like Pepcid, for example. There can be cardiovascular risk for long-term use of NSAIDs, like an increased risk of heart attack or stroke. And there can be risks to the kidneys. So for people who have underlying kidney problems, we might be very careful with our use of NSAIDs. And it can also be problematic if you let yourself get really dehydrated. So one way to sort of make taking NSAIDs safer is to take them with food and to make sure you stay hydrated. There can be some bleeding risk. NSAIDs can inhibit the function of platelets. That's the part of our blood that helps to form blood clots when we need them. And so we don't give NSAIDs to people who are already on blood thinners like warfarin or apixaban or Lovenox. There can be some drug-drug interactions, like with blood pressure medicines like ACE inhibitors, or we already mentioned the blood thinners. For some people with asthma too, the NSAIDs can bring up more asthma symptoms. So with these potential side effects, we have to think about what's the safest way to take NSAIDs. And really kind of the lowest effective dose is the dose you want to be taking, and for as short of a time as possible. So this is a good sort of short-term component of a multifaceted pain medication regimen. We talked about taking them with food to protect your stomach and staying hydrated while you're taking them to try to protect the kidneys. There is a class of NSAIDs called the COX-2 inhibitors, and celecoxib or Celebrex is one that we use a little bit more in palliative care because it has fewer of those side effects. So less of the gastrointestinal risks, less issues with asthma, less impact on blood pressure medications. We'll move on to our next potent anti-inflammatory, which are steroids. Steroids can be used for actually a lot of different problems. Pain is one of them. We use them a lot for bone-related pain, or if there are metastases to the bone, and for any pain that might be inflammatory. We sometimes will use steroids for nausea and to help stimulate appetite. Some examples are things like dexamethasone, prednisone, methylprednisolone. These two come with some side effects, and we tend to think about them as some short-term side effects, and there are some longer-term side effects. Some of the short-term side effects, one can be weight gain and increased appetite. That's actually a side effect we sometimes want to take advantage of to help boost appetite. Some people can feel a little bit irritable or anxiety. Some people feel a positive increase in energy on steroids. Some people have increased blood pressure or increased blood sugar or upset stomach. We typically don't use steroids for prolonged periods of time for pain because of some of these longer-term side effects that can happen, like issues with bone health or osteoporosis, diabetes, high blood pressure, and they can also suppress something called the adrenal glands, which are some of the endocrine organs that help regulate our energy levels. So this wraps up our NSAIDs and steroids, our anti-inflammatory medicines. Let's move on to take a look at some of our medicines for nerve-related pain. So Amy and Jake were talking a little bit about nerve-related pain, and I think of that as the burning, tingling, electric-like sensations, lightning-like sensations, or that pins and needles sensation. For anyone who ever has fallen asleep very, very deeply and your head on your arm and you wake up and your arm is just like you got to shake it out and you feel all those pins and needles, that's kind of the classic nerve-related pain. The medications we have for nerve-related pain or neuropathy can be good at turning down the intensity of what I might call those extra sensations. So if you have more of that burning or electric-like pain, it kind of turns the dial down on how intense those sensations are, and that can be really helpful for a lot of people. Unfortunately, our nerve-related medications don't bring back sensation. So some people come to me and say, Doc, I feel like my fingers are pretty numb. I'm having trouble sort of buttoning my shirt. Unfortunately, our nerve medications typically don't bring back that sensation. We have to rely on sort of the body to heal for that to come back. Some of the examples of the medications we use are gabapentin or Neurontin, pregabalin or Lyrica. We also will use medications that if you were to Google them will come up as antidepressants or anti-anxiety medications, and a class of medications called SNRIs. They do have those positive effects for mood, but we sometimes will use them in palliative care and during cancer treatment for their neuropathic pain relieving benefits. And those medications are duloxetine and venlafaxine. Some of the side effects that can come along with this class and these two classes of medications are some people feel a bit dizzy or drowsy, have difficulty concentrating, or dry mouth. Let's move on to talk about maybe the more topical topic of opioids, which is in the news quite a bit. And I think a main message to take home is that these can be effective and safe tools for treating cancer-related pain, especially when taken under the supervision of a prescribing provider who has experience with them. A lot of people express to me a concern, Doc, I really don't want to take these. I'm really worried I'm going to develop addiction or a problem with them. We, of course, will be conscientious about that, to monitor closely. And I often think about this sort of simple dichotomy, though, to help people understand the difference between an appropriate use of opioids and misuse or addiction. People I see who are taking their opioids appropriately, they're taking them to be in their life. They want to be able to function, play with their grandkids, go take a trip, eat more of their meals. Those people are really trying to live their life. People who have misuse or addiction, they're trying to get out of their life. They want to take their medication to not have to deal with life, to be asleep, to be sedated. So this is something that we monitor, but it's something that I don't want people to feel so afraid of, especially if they're suffering from pain at home and that pain is limiting their ability to live well and to live their life well. As physicians and advanced practice providers, we think about opioids kind of in this chart form. We know that there are opioids that are short-acting, that last for 3 to 4 hours at a time, and there are opioids that are long-acting and last for 8 to 12 hours at a time. Those are on those different rows. And the columns are showing the different ways that the opioids can be taken. Orally, meaning by mouth, through an IV like an injection, transdermal, which means like a patch or a sticker, or sublingual, absorbed under the tongue or on the cheek. So some of the common ones you may have heard of: morphine is available in multiple forms. Hydromorphone, also called Dilaudid, is available in a short-acting oral form and IV. Oxycodone is a common medication available both as a short-acting and long-acting. A few ones to note: fentanyl patches are one of our main transdermal or sticker forms of opioids. And methadone is another common longer-acting pain medicine that we use. So again, just to kind of pull the curtain back on what your providers might be thinking about when they're choosing an opioid, as we think about, well, what's the easiest way for my patient to take this? Are they able to swallow things okay? Do they need something that can be absorbed just under the tongue, on the cheek? Do they need a patch? And then we think about how it's metabolized. Is this person's liver, their kidneys, are they working okay? How can I make my best selection based on all those factors? I wanted to take a moment to talk about some pro tips when taking opioids. For any medication that you're taking orally or by mouth that you swallow, it needs to go into the stomach and often is getting absorbed in the small intestine. So it can take about 30 minutes for any oral medication to really start taking effect. And it can take about 45 minutes to an hour for it to reach its peak or maximum effect. I'm sure many of you all know this by just your experience. But because of that length of time that it takes for those medicines to reach its maximum effect, we often recommend that if you're taking, for example, a short-acting and a long-acting opioid, that you wait at least an hour between them, so that you can imagine if you took a short-acting opioid that's going to last for 4 hours, and it's taking an hour to come on to get your full effect. If you had taken a long-acting opioid within that hour, you might now have a lot more of that medication in your body before you knew what the first pill you took was going to do. So for safety reasons, we really recommend separating your oral medications at a minimum by 1 hour, so you know what that pain medication is going to do before you take the next one. As we mentioned, most of those short-acting opioid medicines last for 4 hours. If you're taking those in a shorter interval, like every 1, 2, or 3 hours, you're going to be inadvertently increasing your dose. So really follow kind of your doctor's recommendations about this for safety. We also recommend that you don't drive until you really know how those medicines are going to affect your body and that you're on a stable dose. So those are a few of the pro safety tips while taking opioids. A few side effects to think about: some people can develop nausea with opioid medicines. Fortunately, this typically can improve after about 5 days or a week, as long as you're kind of continuing to get exposure to the opioid. If it's a challenge to get through that, we often recommend taking an anti-nausea medicine about 30 minutes to an hour before taking your opioid medicine, so you get the maximum effect. Sedation or grogginess can be a side effect. Often, actually, people can get a little bit more accustomed to that, and that can reduce over time. But this is a side effect you really want to keep your prescribing provider aware of, how you're feeling with that in case changes need to be made. Constipation is one that unfortunately does not improve over time. The body doesn't get used to the constipating effects of opioid medicines. So we kind of have a rule in palliative care. If you're writing a prescription for an opioid, you're writing for a prescription for a stimulant laxative or a stool softener to help people have regular bowel movements. Concerns about overdose. People should not be overdosing on their medicines if they're taken as prescribed. That being said, we recommend having naloxone or Narcan, which is the opioid reversal medicine that's a nasal spray, co-prescribed with opioids. I really recommend that if you have an opioid at your house, you have this medication in your house. Just, if someone ever got into your medications who wasn't supposed to, a child got into them, you made just an honest mistake in taking your medications. We recommend having naloxone in the house. Let's talk a little bit about medications for mucositis, and I saw there's some dentists in the room and on the panel later, and they may have additional recommendations around this. But mucositis is that inflammatory reaction that can happen with chemotherapies and with radiation therapy. It can cause sores in the mouth and be incredibly painful. Fortunately, we do have some topical solutions to help with this. You may have heard of something called Miracle Mouthwash. Miracle Mouthwash is somewhat of a generic term, and there can be different formulations of this. Commonly, it includes something called viscous lidocaine, which is a topical numbing medicine. Diphenhydramine, which is actually Benadryl, is a potent antihistamine and has some anti-inflammatory components. And then Maalox, which think of that as sort of coating the mouth a bit. Research has had mixed recommendations about whether or not using things like Miracle Mouthwash ultimately help to improve pain relative to other things. We often will use at least viscous lidocaine in our palliative care practice. Some people recommend doing salt and soda mouth rinses to try to help reduce pain. We also have other topical medications that are swish and spit options. The nice thing about these medicines is that you're not taking something that's affecting the entirety of your body. You're treating pain right where it's happening, just in the mouth. Those topical medicines can include dexamethasone, which is one of those potent steroid medicines. Sometimes even swishing with a morphine solution. You're not swallowing it, but just the topical application of morphine can sometimes reduce pain in the mouth. And then a unique medication called doxepin that actually, again, if you were to Google it, would come up as an antidepressant or anti-anxiety medicine, but topically it can relieve some of the nerve-related pain. When mucositis is advanced or extremely severe, we think about using our opioid medicines, and often people might need that transdermal fentanyl patch or that fentanyl patch that's in the form of a sticker so that it's absorbing into your body without having to swallow. And then some people need to be admitted to the hospital to have something called a patient-controlled analgesia, or a PCA. This is a button that administers a low dose of an opioid but can administer it frequently in a hospital setting if mucositis gets particularly bad. We do sometimes use topical agents, so sometimes I'm thinking about if there's been burns to the skin from radiation or irritation to the skin from radiation. We might use lidocaine, which is a numbing medicine. Diclofenac or Voltaren is an anti-inflammatory. Capsaicin is kind of the hot pepper ingredient that can sometimes provide relief to superficial pain. And then there are compounding pharmacies that will offer different compounded medications, including cannabis products like CBD and THC or ketamine, and there's a lot of other compounding that can happen at compounding pharmacies. I'll reiterate some of what Amy and Jake had left you with, is that we want you to get help with your pain and to get help with pain medications. So please let your providers know how you're feeling, how your pain is feeling, and especially how it's affecting your life. I think sometimes it can feel hard to communicate how the pain feels, and advocating for yourself by talking about, this is how it's affecting my life, doc. We really need to do something about it, can really help get that provider motivated to say, you know, you're right, we've got to do something better for your pain. Consider asking about, hey, what happens if my pain gets worse over the weekend or when I get home? What should my next step be? Advocate to try to get more of some anticipatory guidance or plans for what to do next. And then, of course, our palliative care team is here to support, so you can always ask for a referral to our palliative care team. We'd be happy to talk about a pain management plan for you. Thank you all so much. I hope this was helpful to review some of the common medications, and we'll have Lindsay up next to talk more about some non-pharmacologic interventions, and we'll take questions all together in just a moment. Thank you so much.